you for giving me another chance. I am grateful to you for giving me a chance another time to speak on this in your Eco Pakistan. And I sincerely wish and pray that sometime we may come and someday and give a physical presentation. We are hoping for the day. Now, we are all seeing cases of rheumatic myelostenosis, but in the last few years, we have seen many cases of a non-rheumatic. So this is just to highlight these cases, and it will purely be a case-based presentation. And I fear it will be only for the eco persons or so. Now, the etiology of the myelostenosis can be divided into primary, secondary, and functional. Primary is always rheumatic, and we know it is a major cause of the world disease globally, especially in the developing countries. In Western countries, the incidence of rheumatic heart disease is very less, as a result of which other etiologies are getting more prevalent. So we'll get into those also. Now, these are all aware of these myelostenosis rheumatic. Everybody knows that these are the thickening of the cusp, doming of the cusp, and all these features are very well to all of you are known. Now, coming to secondary one, we are going to be no, the first one is more important is a degenerative myelostenosis cause of a mitral annular calcification. It is mostly seen in Western population. It is the effect of increasing life expectancy and comorbidities, and it has emerged as a very leading cause. And we are also seeing a fair number of patients of a degenerative myelostenosis. And the basis of this is that this is the annulus to which the leaflets are attached. There is a calcification of the annulus, and this calcification encroaches on the inflow and uh, on the leaflet also. So the tip of the leaflets are free, but it is encroaching on the leaflet, thereby narrowing the mitral orifice area and it is reducing the diastolic annular expansion. For example, just you see a calcific myelostenosis is a disease of the annulus and not of the leaflets, while the rheumatic myelostenosis is a disease of the leaflets but not of the annulus. So these are the basic difference in this. Now, the incidence in various studies have been varying, but it is overall 12.5% of all cases of myelostenosis. So this is the overall incidence in in cases of now. Now you see here, this is a classical case of a mitral annular calcification, and you see a turbulence across it, and you see the leaflet attached to the annular calcification. So that is the reason that, and you see turbulence across it. That is why every case of a mitral annular calcification which we get, we always try to exclude the presence of a myelostenosis because of a color flow mapping. And you see, even on a 3D echo, you can see this is the annulus and this is the calcification of the annulus, thereby narrowing the mitral orifice. Now, the assessment of severity is of a very big problem in these cases. Neither a 2D planimetry helps, neither a 3D helps. And those who are doing an echo, they know that the pressure half time in these cases overestimate the mitral valve area. So because of all this calcification, this is not possible. So they have been suggested of what is known as a mitral valve dimensionless index. Now, in this, what we do, very simple thing, we take an LVOT and calculate the VTI, velocity time integral, and then we take a mitral valve VTI. The lower the ratio, the greater the severity of high, because as the myelostenosis increasing its severity, its gradients increase, and this VTI also increases. While this remains constant and this increases, so the lower the area. So it has been shown that those who have got the area less than 1 centimeter square, this ratio is 0.31 to 0.04. And then as the ratio increases, the area also increases, going to 1 to 1.5. So that the best is to always take a dimensional index and that can help in these cases. Now, to the take-home message for this is that do not ignore mitral annular calcification just as an old age phenomenon. Always liberally study by color flow mapping and Doppler and diagnosis as degenerative MS, but don't write mitral stenosis. Because if you write mitral stenosis in a 65-year-old person, then it becomes a problem. So you write a degenerative mitral stenosis in these cases. And we have been interested. The management has always been very unsatisfactory because we know we want to go to detail. The surgical management is quite uh, bad in these cases because of their age, multiple comorbidities, and the other thing is you do not know whether the symptoms are because of this or not. So mainly a medical therapy has been tried also, unless a stage comes when there are novel therapies and they, because of calcification, the mitral wall replacement is also risky. So most of the time it goes uh, into the palliative therapy. Now this young lady with a mitral stenosis, you can see a good opening of the mitral wall, and before the earlier we used to classify 1.2 centimeters as a moderate mitral stenosis before the ACC-AHA classification came. So here you can see there is a good opening of the mitral leaflets, and the mitral wall area is 1.2 centimeters square. But when we go to the apical view, we see that there is a significantly increased gradient, which is 34 and 23 mm Hg, which is much more than expected with a 1.2 centimeter square. And when by a pressure half time, the mitral wall area was 0.8 centimeter square. So that means this continuous wave Doppler was interrogating all the structures, including the subvalvular apparatus, and this produced this thing. And when we did a color flow mapping, you see the obstruction is much beyond the mitral wall area in the region of subvalvular fibrosis. And you see here, you see the thickening, but although it was a rheumatic case but it was, you see it is subvalvular stenosis should also be well recognized in these cases. Now, because of a young age, a balloon dilatation was attempted because rather giving a ball replacement, and this was left with a fairly good mitral regurgitation, but the patient is still being kept under observation to see how these symptoms continue to grow. So this subvalvular region must be studied, that this can be a cause of this stenosis. This was this patient first came to us in January 2005, and we have been following her up till about 2018. At that time, her age was about 36 years, with a controlled hypertension for 2 years. A cerebrovascular accident occurred at 3 years back, that was at the age of 33 years, with a complete recovery. Clinically, a murmur was heard in the mitral area, and somewhere she was diagnosed as a rheumatic valvular heart disease. So at one stage, a mitral wall replacement was considered, and then she was referred just for a prior pre-surgical evaluation. Now, as you see, definitely there is a signs of a mitral stenosis are present in the form of doming, thickening, and all other features are seen. But the one point with the next slide, with this give us an indication that we are not dealing with a rheumatic mitral stenosis, and we'll come to it that why we are not dealing with a rheumatic mitral stenosis despite all the other signs. And you see that the color flow mapping, there was a significant stenosis and a regurgitation. Now, why this was not a rheumatic stenosis? This is zoomed view. You see the marked fibrosis of the mitral cusps. The posterior leaflet is very fibrotic, moving very poorly, and there is an endomyocardial thickening. And the main thing was there is a large thrombus present at the apex. So, in the absence of any wall motion abnormality, the presence signs of a mitral wall involvement with a thrombus at the apex gave us a diagnosis that we are not dealing with a rheumatic, and this term is hypereosinophilic syndrome. And you see there was a substantial restriction of the PML motion. There was the endomyocardial thickening, fibrosis of inflow regions, and apical obliteration. So that was the case that gave us a diagnosis, and this was mistaken by the earlier eco people, not their fault. Possibly they might have not seen such a case. And it is defined as a persistent and marked stenopedia for more than 6 months. That is because of an eosinophil-mediated and organ damage. Now, this has a surgical management issues because of shortage of time. We'll not go into in the detail, but many of these walls undergo a thrombogenic, they develop a thrombosis also. So the attempt has always been made to give a tissue wall also. So because of this thrombogenic thing. Another case, a 48-year-old lady who was on anti-cancer therapy, she reported with a systolic murmur and also the presence of some tricuspid regurgitation. And this was noted. There was a marked thickening of the cusps, and you see there is a thickening of the intervalvular fibrosa, and there was all the cusps were thickened. So so this was when we went into history with an anti-cancer therapy, which was and the radiation was given. At that time, the radiations were given as a diffuse thing, and not a localized thing was given at that time. So this was a radiation-induced valvulitis following a breast cancer, and it is a very long latency period. This patient came to us almost about 20 to 25 years after this radiation. Now, the longer the duration, they develop more of a regurgitation rather than a stenosis. And the problem of surgery in these cases is the presence of chest wall scarring, concern for delayed wound healing from radiation, presence of present cardiac surgery, previous calcified aorta, and various other calcifications and significant cases. As a result of it, the surgical treatment has always been associated with a poor prognosis. Then there can be another secondary causes like a genital or a non-rheumatic. We have seen congenital can be any lesion as supravalvular, valvular, or subvalvular, various types of a balls which have been seen, which can produce a congenital mitral stenosis that is a non-rheumatic. This was an 18-year-old girl having dyspnea, easy fatigability, one episode of hemoptysis, a murmur suggestive of mitral stenosis, and she was referred for evaluation by echo and for a balloon mitral valvotomy. But when we did the echo, we found something that besides mitral stenosis, there was a called triatriatum. You must have seen this case in the morning. So this normally we don't see this combination, but this combination is usually very uncommon, that the presence of both the called triatriatum and the presence of mitral stenosis in the same patient, and then this patient was put into a surgical, she underwent a surgical therapy. Again, a 26-year-old patient, asymptomatic, except for mild cough, clinically NAD, and because of this mild cough, she was referred for a echocardiogram and then there we detected a routine thing, and what we detected was the presence of a double orifice mitral valve. You see, there are two orifices, one this and one small, and they are separated by a fibrous band. And you can see also these two orifices can also, two mitral wall lesions can also be seen here. And this gives you sort of what is known as the spectacled appearance of this double orifice mitral wall. Now, this is not the same patient, but it's just to tell you that there are two different orifices, and they flow across the different, and they may have their own quality and the papillary muscle. So this is the same thing they can present. It is a very rare condition, 0.01 to 0.6%, and we split into two orifices separated by a ridge of fibrous tissue, and may be asymptomatic as this patient was. Only there are other associated congenital lesions which can be present, and then they produce various symptoms of a or stenosis or regurgitation, and we do a monitoring and avoid, and the surgery is done as a last resort. Now this was a boy, you can see who had a differential hypertension, and you can see here also there's an obstruction at the mitral wall level. There is an obstruction at the aortic wall level, which shows a doming of the aortic cusp and the mitral wall. And this shows a single papillary muscle, and the splitting is there, so it is not traumatic, and you can see a single papillary muscle attached to the mitral wall, indicative of a parachute mitral wall. And on the suprasternal view, there was a coarctation of the aorta. So that this patient turned out to be a partial
Excuse me,
stone
Dr. Parashar.
complex
I'm sorry.
because of the multi-level left side obstruction. There was obstruction at the level of a coarctation, obstruction at the level of the mitral wall, obstruction at the level of the aortic wall, but with a parachute mitral wall, but the other supramitral rings were not present. Coming to the last
Sir,
thing, a
excuse me,
functional
sir.
already discussed in the morning.
Dr.
So
Parashar.
these are some of the conditions which can cause a transient obliteration of the mitral wall, and the conditions are very well known. So once they cause a transient constriction, there's a variable murmur, which is a variable type of a murmur which is seen in these cases. And here you see, this was a 41-year-old lady, immunocompromised, fever, heart
Dr.
failure,
Parashar, I'm
and
sorry. Dr. Parashar.
there
Can
was
you hear me, Dr.
a
Parashar?
mass. This could have been a vegetation or the presence of a tumor or so, and this turned out to be aspergillus also, that which was going and coming in the mitral wall. Again, the same thing. Now this is the atrial myxoma. You see, it goes into the mitral wall during diastole. And now many of these cases are only diagnosed as mitral stenosis, and they are just routinely detected these tumors also. And when they obstruct this, they produce a functional stenosis, and thereby there is a variable murmur depending upon the posture also. This was the patient with a quite sick patient with a heart rate of 120. She had both MS and MR, but the question was that why she is having MR and is with the multiple a tumor or so. And then we detected that this
Dr.
MR
Parashar,
was
excuse
because of the
me.
perforation of the anterior mitral leaflet. This was coming and hitting the anterior mitral leaflet, producing a perforation in the leaflet, and hence the perforation led to a both MS and MR, and this patient underwent a surgery and the mitral wall replacement. So any of these things can produce a transient stenosis, and which disappears after the treatment. Now, this is not related to the present talk, but this incidental came about
Hello.
few days back. We saw this case of a right atrial myxoma. You can see, and you see in the thing, the same. I keep my LV on the left side, so you see the right atrial myxoma, and it was obstructing the tricuspid wall, and thereby producing a tricuspid
Uh,
stenosis, which will disappear after removal of the cusp.
Dr. S.K. Prashar,
So
excuse
coming to the
me.
summary, we should not jump straight to echo. I still feel it nothing to replace a good clinical history and examination. And then you go to the echo, always study every aspect of echo. Any abnormal finding, explain why. Say, because if you find anything, you have to explain why this finding is there. There is a liberal use of covered for matter and Doppler, and non-rheumatic mitral stenosis have got their own